And it's now my great pleasure to introduce a good friend and colleague, Dr. Katherine Fuh, who is Associate Professor and Director of Basic and Translational Research in the Division of Gynecologic Oncology at UCSF. She's actually one of us because she received the clinical training here at Stanford, including your fellowship. She had a PhD in cancer biology here at Stanford with Amado Gacha. She has been amazingly successful. She does run an NCI-funded lab, is leader on national committees, including the translational co-chair for Uterine Corpus Committee for the NRG clinical trial groups, and many others. So we're looking forward to your talk, Katherine.
Thank you. Thank you so much, Oliver, for the invitation and for the introduction. And, since I've known Dr. Barrick as a second-year resident in OBGYN, when he started as a chair in chair in OBGYN, and just the impact you made on my career and my approach to GYN oncology, and hopefully we'll demonstrate the positive impact we made on our patients as well from everything. And good to see you, Deborah. So with that, I'll really tell two stories. The first one, sorry, I can't see folks over there. The first story is really what was born here at Stanford. So I'll go through the AXL story that Aaron Rankin certainly led when we were both in Amado Jacha's lab. And then the second story is one that I've developed when I was first at WashU and then currently continue at UCSF. So this slide really highlights some of the summaries of what Dr. Bix and Dr. Chen have also showed in terms of, what do we have now? And you'll see the focus has been PARP inhibitors and antibody-drug conjugates, but I'll really highlight that this really pertains to a portion of our patients. Certainly the 50 to 75% who don't have BRCA1 or 2 mutations that really can't benefit as well to PARP inhibitors, as well as those we just heard about the ADCs and how perhaps it's not really yet curative. And so really that really allows us to think about other opportunities to develop new treatments. And so my lab in particular has been looking at platinum-resistant ovarian cancer. And partly you can see that every time there is a new therapy in this space, the objective response rate does decrease and the progression-free survival also decreases. So really, this is a much needed area for our patients. And one of the logical ideas in terms of approaches of how do you identify new targets. And one is, why not look at the genetic mutations? And so this, you've heard from others that high-grade serous ovarian cancers really have low somatic mutations and really are highlighted by the high copy number alterations. So this has led ourselves and others to look at perhaps protein expression. We've heard the story about the folate receptor with mirvetuximab and in HER2, trastuzumab deruxtecan with HER2. And Erin Rankin, when she was a postdoctoral fellow in Amado Jacha's lab, was able to identify AXL. And so she and I together had really been looking at AXL in terms of the expression level. And we did find using our patients here at Stanford initially that AXL was highly expressed. And this was back in the day, Brooks or Dr. Howitt. So we looked at ovarian surface epithelia as our normal back in the day before we really understood the fallopian tube. And really found that AXL is more highly expressed in ovarian high-grade serous cancers, about 80%. And then when we looked at the Kaplan-Meier curve, we found that those patients with high AXL expression in the tumor cells had lower survival, both progression-free and overall survival. And so this had led us to really understand, what is AXL? What is this ligand? So we found the ligand was Gas6, and that has led to when it attaches to AXL, it really leads to the process of metastasis, which we all are very familiar with. Gas6 AXL expression is not only unique to GYN cancers. You can see in other cancer types. It was initially discovered in CML and as well as been really looked at in AML as well as other tumor types. So to kind of quicken this story, so it did take us about 10 years to really go from the laboratory, actually maybe 15 years, to clinical trial. But then early stages, we collaborated with Jennifer Cochran, who I believe is still here at Stanford, and Mahalis Kariolis, who was a graduate student at the time. And they really engineered this AXL decoy receptor. And this really binds to Gas6. And they were able to do 2 iterations of this really high binder to Gas6, which then would inhibit AXL and its activity. And these are 2 pivotal papers that the Cochran lab, as well as in Amado's lab, also published. And so from this was born Betiresept or AVB500. And so in our laboratory, we utilized this therapeutic agent and asked the question for those tumor cells that were actually more resistant both to paclitaxel and carboplatin. If we were to treat these cells, these high-grade serous ovarian cancer cells, together with carboplatin and or paclitaxel, could we actually find a decrease in cell survival? And indeed, we found that was the case. You can see here outlined, this is a very typical clonogenic cell survival assay. You can see the combination of carboplatin with AVB500 or Betiresept really did decrease that survival. We then utilized our mouse models, both subcutaneous with both xenografts as well as patient-derived xenograft models, as well as intraperitoneal models. You can see the same, that when combined with carboplatin and paclitaxel, Betiresept or AV500 with chemotherapy really decreased that tumor burden, suggesting that this perhaps could be a strategy for platinum-resistant ovarian cancer. So fast forward, I guess 10, 15 years, we finally were able to lead from a phase 1 trial to a phase 3 clinical trial. And this is a summary of the phase 3 clinical trial that I was fortunate to lead with a colleague in NGOT, Antonio Gonzalez Martin, in which we were able to enroll platinum-resistant ovarian cancer patients. And they had 1 or 4 prior lines of therapy with the stratifications you can see listed there. And really just asking the question for those patients who received standard of care, which was weekly paclitaxel, compared to weekly paclitaxel plus Betiresept, could we see a difference in progression-free survival as well as overall survival as a secondary endpoint? And at the time, as a sort of context, there's 2 other clinical trials on platinum-resistant ovarian cancer, also using weekly paclitaxel as a backbone. And I would say that these 3 clinical trials found very similar results, which is that weekly paclitaxel was, very therapeutic. So you can see that there was really no improvement in survival with the addition of Betiresept when compared to weekly paclitaxel. And this was a PFS as well as OS. But this really made myself, and I remember talking to Erin a lot, pause and think, but in the laboratory, we really found a significant difference. So how can this be? And so when we designed the trial, it was such where we thought, because of financial logistics, which when anyone in clinical trial design will understand in terms of biomarker development versus running the clinical trial itself, we really focus on the idea of the clinical trial. And so included in this trial were patients with platinum-resistant ovarian cancer, not necessarily looking for and stratifying with AXL high expression levels. So we went back with Terry Longacre, and this is just a year ago. So we went through every tumor actually, and this is at baseline of when they were initially diagnosed, and asked the question, can we recategorize who were really the high expressors? And when we did this and looked at the correlation, we did see a difference. And what we found was that for those patients with really high AXL expression, they really did benefit from the combination of Betiresept and paclitaxel compared to paclitaxel alone. And what I mean by that is that when you look at the actually progression-free survival for those with high AXL treated with paclitaxel alone, the PFS was only 3 months. But when we actually gave in combination with Betiresept, it went up to about almost 6 months. And the overall survival data was even more impressive. You can see in the teal curve there that when you receive Betiresept and paclitaxel, survival OS of 17.8 months compared to 8 months only if you had high AXL, but only paclitaxel alone. And this is really significant because as one of the patients who, with her permission, has allowed me to share her picture, she was on the trial for, 2 years and has been NED since off the trial about 3 years now, and she's at WashU. So this has really made an impact, I would say, for this patient, hopefully for others. So as we're thinking about the overall survival data, you really saw that significant difference, but perhaps not as much with the progression-free survival. So that leads us to ask, well, how can this be? What else could be at role? Perhaps it's not just the tumor cells that are really making an effect, perhaps the stromal cells, perhaps the immune cells. And so the arrowheads really show you when you look at these tumor specimens, you can actually see a difference also in the AXL expression levels of the stromal cells. And we actually evaluate the progression-free survival or overall survival with low stroma AXL versus high. You see the same difference. Those tumors that have high AXL in the stroma actually had worse survival as well. And it's been well characterized that AXL, this RTK, and the tumor cell side can actually be very immunosuppressive. But what is not known as much is about the fibroblasts. How do the fibroblasts actually perhaps regulate immune evasion or immune suppression? And so we try to answer this question by taking cancer-associated fibroblasts cultured from the tumor momentum and just ask a simple question of a cytokine array and said, for those cancer-associated fibroblasts with high AXL expression, do they happen to actually perhaps express more or less immunosuppressive cytokines? And we found that actually those cancer-associated fibroblasts with lower AXL expression had increase in cytokines such as IL-15. And we also validated this again using a different cancer-associated fibroblast you can see on your right and asked a similar question. And when we think about IL-15, it's a cytokine well known to activate NK cells. And so we looked at it biologically using NK cell migration assay as perhaps a readout for this. And so these are taking, and you saw this, I think, in Dr. Rankin's presentation, we're really being able to utilize this Boyden chamber where we can actually see cells migrate. So we asked the question if these NK cells can actually migrate towards faster if the cancer-associated fibroblast condition media were actually deficient of AXL. We found indeed that was the case. So for those NK cells that were co-cultured in media that had low AXL expression in the fibroblasts, they actually migrated better. So, and we saw the same in terms of when they were co-cultured first and then able to migrate towards fetal bovine serum. So really highlighting the idea that the cancer-associated fibroblasts media that was expressing AXL was actually more immunosuppressive. And when you actually deplete AXL, you have more NK cell migration. We found the same thing with our T cells using JERCATs as a surrogate for T cells. And so this is just one sort of quick and short story about how development of AXL inhibitor as treatment options of ovarian cancer, how, really demonstrating the bench to bedside development. This was a quick sort of 5-7 minute talk, but really that highlights about, a decade plus more of work, really showing how we can really make a difference, hopefully in our patients, and how the phase 3 clinical trial in platinum-resistant ovarian cancer had this exploratory finding of improved response in tumor AXL expression. And how we're more recent work really looking at the cancer-associated fibroblasts and how the AXL expression can correlate with worse survival, and depleting this can actually hopefully improve immune activating cytokines and really future directions that we're going into our lab in terms of how to really make a bigger impact for our patients. So I'll spend the next 5 minutes really highlighting a quick other story about a functional genomic screen that we performed in the lab, utilizing the fibroblasts you saw from Dr. Rankin's talk about the tumor microenvironment. And in this case, this is way back before CRISPR was really, so this is one of my first screens that we did when I did as a faculty member. So I'm aging myself, but we did an siRNA screen. And from this screen, we really wanted to ask, when we co-culture tumor cells with fibroblasts, can we actually identify new targets that can actually prevent invasion and perhaps metastasis? And we did identify discoidin domain receptor 2. It's a collagen receptor. It's expressed both at the tumor cell and the stromal cells. You can see highlighted there. So mesothelial cells, fibroblasts, as well as tumor cells. So then how do we actually distinguish the role of DDR2? Well, we did look at our patient tumors, and this time we really stratified from DDR2 tumor expression and stromal cell expression, and really highlighted in the purple curve, highlights the DDR2, I would say the strength of it, meaning that for the patients who had high DDR2 in the stroma, they actually had worse survival if they had high DDR2 in the tumor. So this led our lab, and this is a summary, to really deplete DDR2 in our stromal cells, both mesothelial cells and fibroblasts, and show that we can actually decrease metastasis when we deplete DDR2 in the microenvironment cells. And then also we see this in a cancer-associated fibroblast, and we'll have time to go into this work, but showing how it regulates collagen production and extracellular matrix, and that really leads to remodeling and promotes metastasis. When we deplete DDR2, we can actually decrease this and decrease metastasis. So more recent work in the lab has really understood and tried to understand the immune response to this. And so this is a figure of a syngeneic mouse model in which we deplete DDR2, and we can see that the mice live longer. And then we, of course, asked why. We do see that those with DDR2 depletion these mice have higher immune response and perhaps activation and regulation. And so when we look at these tumors, we do see increase in immune cells in our knockout mice, so DDR2 depleted. And we also see in these immune cells, particularly T cells, helper T cells and cytotoxic T cells. And we look a little bit closer, we can see that there's an increase in activated T cells as well. And the final few slides really highlight some of the direction that we're going to right now, which trying to answer why. And so using sort of this nanostring approach in transcriptome, we were able to understand and identify arginase 1 mediated immunosuppression, typically in the MDSCs, and we found that arginase 1 is more highly expressed in DDR2 expressing tumors. And so we wanted to ask the question, is it specific to fibroblasts or is it particular to macrophages or tumor cells? And this work really shows when we compare arginase expressing cells, both in the fibroblasts, macrophages, or tumor cells, that we see there's really more of a decrease in arginase expressing cells in the fibroblasts. So really highlighting the tumor microenvironment in terms of the fibroblasts and how they might regulate immune activation. So the summary for this is that Genomics screen did incorporate the fibroblasts and tumor cells and really identified this collagen receptor that we've identified as a key factor in early invasion and metastasis, and that fibroblast DDR2 depletion can prevent tumor cell metastasis and perhaps increase proportion of activated immune cells. So the better understanding of arginase 1 and DDR2 expressing CAFs in regular immune suppression is a future direction in our laboratory, and hopefully be able to share more information in the future about how this can have a positive impact on our patients. So that just really want to acknowledge the folks that did the work. I spent significant time at WashU, so you can see the folks that were involved there. And of course, here at Stanford with Aaron, who was critical in my initiating this, the Axel story and carrying this forward to our patients, and then current collaborators, and of course, the funding sources. Thank you.
Well, thank you, Katherine. Great talk, and congratulations for moving a discovery that you made here with Aaron into the clinic. I actually do remember your thesis defense. This was in my first year here.
Yes.
Any questions?
Very exciting work. Thank you. Very interested in the DDR2. Have you looked at the effect of that on tumor debulkability? Because as you know, in ovarian cancer, your great surgeon's ability to debulk is very predictive in outcome. And I'm wondering, tumor aggressiveness, tumor implantation, is there any association with DDR2?
Yes, Dr. Kapp, that's a great question. We did actually look at that question and utilize proteomics to try to answer that. So we did take patients pre and post neoadjuvant chemotherapy with high-grade serous ovarian cancer. We found that those patients who did not respond as well to neoadjuvant and perhaps had a more difficult time at their cytoreductive surgery did have higher DDR2 expression. We did this in small numbers, about 10 pairs. So we certainly need to really validate this with a bigger cohort, but it is certainly perhaps correlative to that. Right. Yes, exactly. Or develop the therapeutic agent to DDR2 that can then hopefully help in the maintenance setting.
Thank you. Any other questions? Can I ask a question?
Oh, sure.
Do you know how AXL suppresses NK cell function? What's the mechanism?
We are not sure right now. We're really looking into that. But I agree, it's very curious, and we're utilizing different models to try to understand that. But yeah, we're not sure yet.
Thank you so much, Katherine. Great work.
Thank you.